So we are going to get started, and it's really an honor for me to get to choose who comes to this session and to get to do that. Dr. Charles Yeo and Dr. Lilimo, thank you for being here today. Thank you for coming to San Diego, and thank you for coming from the East Coast twice within a week to share this experience with me. True to the title of this session, you are both legends in GI surgery, but more importantly, you're legends to me. And I'm grateful for the role that both of you played in my career. I'm just going to do a brief introduction before we start the conversation, but Dr. Yeo is currently the Samuel D. Gross Professor and Chair of the Department of Surgery at Thomas Jefferson, as well as Senior Vice President and Chair, Enterprise Surgery at Jefferson. He grew up in New Jersey, like I did. He went to Princeton and undergrad, and then came to Johns Hopkins for medical school, graduating in 1979. He did his surgical training at Hopkins and did 1 year of research at SUNY downstate, and then completed his ACS or super chief year from 1985 to 1986. He then joined the faculty and he rose to full professor by 1997. In 2005, he became the 8th chair at Jefferson, and we left Hopkins right about the same time. Dr. Yeo is the editor-in-chief of the highly successful 2-volume Shackelford Surgery of the Alimentary Tract. He subsequently gifted that to the SSAT. He served as associate editor of Advances in Surgery and associate editor of the Journal of Gastrointestinal Surgery from 2006 to 2011, then co-editor-in-chief from 2011 to 2016. He's authored well over 500 peer-reviewed papers and over 100 book chapters and has an H-index of 107. But I met Dr. Yeo as a medical student in the 1990s, and after my rotation in surgery, I wanted to be a surgeon. So I approached him about research. I literally had zero research experience, but he gave me a chance. He showed me the Hopkins pancreatectomy database, which maybe at that time had 150 patients in it. And timing and opportunity were certainly on my side. We converted that database to a durable electronic format and collected all the Whipples back to the first one in 1971. And then we kept it updating throughout my training. And this opportunity and the mentorship of Dr. Yeo and Dr. Lilimo and Dr. Cameron really launched my surgical career. I've had the opportunity to complete all of my surgical training with Dr. Yeo as a mentor. I did my first Whipple and my first distal pancreatectomy with Dr. Yeo. And I can tell you, he is technically unparalleled. I, on the other hand, am not naturally talented, and I'm sure it was incredibly frustrating to teach me how to operate. I remember finishing my training with Dr. Yeo, and I thought, I'm really good at this. And then I realized I was just standing there, and he was just doing the Whipple around me. He said, just don't move your needle. You'll be happy to know that I learned and I became actually a decent surgeon. Dr. Keith Lilimo is the W. Gerald Austin Professor of Surgery and Professor-in-Chief of the Department of Surgery at the Massachusetts General Hospital. Dr. Lilimo grew up in South Dakota and completed his undergraduate education at the University of South Dakota. He too went to Hopkins Medical School, graduating in 1978. He and Dr. Yeo were co-residents at Hopkins and completed their ACS year in 85. He too joined the faculty and rose through the ranks and served as associate program director for 10 years. In 2003, 2 years before I finished training, he left to become the J. L. Grossfield Professor and Chairman of the Department of Surgery at Indiana University School of Medicine. There he built an amazing Department of Surgery. And I really think a good leader creates something that persists long after they've gone. And Dr. Lilimo certainly did that in Indiana. In 2011, he left in Indiana University to become the Surgeon-in-Chief and Chief of the Department of Surgery at the Massachusetts General Hospital. Dr. Lilimo served as President and Chair of the Board of Trustees for the Society for the SSAT. He served as President for the Society of Clinical Surgery and the Society of University Surgeons, as Recorder and President of the American Surgical Association. In 2018, he was elected to membership in the National Academy of Medicine, the American College of Surgeons Academy of Master Educators. He's the Senior Director of the American Board of Surgery. And he's also the recipient of the Harvard Joseph B. Martin Dean's Award for Mentorship for Women, and was selected as an honorary member of the Association of Women Surgeons. His bibliography similar to Dr. Yo's with over 500 journal articles and 140 book chapters. He's a former editor of one of the leading surgical texts and served as editor-in-chief of Annals of Surgery, just very recently passing that baton to Justin Dimick. Dr. Lillimo mentored me on so many projects, and in his role as APD, advocated for me in many ways. In our 4th year of training, we had the opportunity to go to England or Ireland to train, and at that time my dad had lymphoma. I was undergoing a bone marrow transplant, and I didn't want to go. And he really advocated for me. Dr. Cameron was not a popular thing at the time. I didn't get to operate with Dr. Lillimo as a PGY-5, but he consistently has been a sponsor throughout my surgical career, and he's an outstanding surgeon, but his strength and loyalty and his constant effort to advance the careers of others is remarkable. Both Dr. Yo and Dr. Lillimo cared about me as a human being. I can't count the number of times I would be over their home for Thanksgiving or other holidays when I wasn't able to go home. They would take me to Orioles games, and I got to babysit their kids. They introduced me to everyone at surgical meetings. Charlie, Keith, Terry, and Cheryl came to my wedding in 2004. Keith and Cheryl had to fly in from Indiana. They've both been chairs for 20 plus years. And over this time, academic medicine, surgical training, paths to success, and really the role of the chair has evolved significantly. You both have weathered this storm and have very valuable perspectives. You know, for the audience, I sent them some questions, but this is generally not scripted. And if we have time, we can certainly take questions from the audience. But I'll start by just saying, like, looking back at my time at Hopkins, it was definitely one of the best times of my life. You were residents and ACSs together, and then you and your families became lifelong friends. So tell me about the beginning of residency and how you became friends, because actually I'm not sure I know that story.
Go ahead.
I thought you were doing this one.
Okay. So you couldn't probably find two more opposite backgrounds. Taylor sort of outlined it. I'm a farm kid from South Dakota, went to University of South Dakota. He's from New Jersey, went to Princeton. I transferred to Hopkins for my 3rd year of medical school after 2 years, and about that time I met Charlie. He was a year behind me, and sort of got to know each other through those last 2 years. And you know, I was married to Cheryl at that time, and there were times that Charlie was the most eligible bachelor in all of Baltimore, I think, there for a while. But we got to know each other during medical school, and then he was a year behind me in the residency. And as Taylor said, he spent a year in the lab, and I spent 2 years. So we joined as chief residents, and you added Steve Bowling to that group and Tim Buckman. We were the chiefs for the last 4 years together, and it was very special. And as Taylor said, we've become lifelong friends. I think it's just working side by side with people, and you know, likes is opposite. We were in backgrounds. We had a lot of similarities, and we just sort of became friends, but really cemented during the 3rd year when we were co-3rd year residents together. I think that's when we really bonded the closest.
I would just add one thing, and that is whenever we were finishing the residency and looking for jobs, John Cameron had just really been named the new chair to succeed George Zeitema, and we ended up both staying at Hopkins. But whenever I talk to new faculty now, we didn't have enough offices for us. So we had to share an office. We basically had one desk and 2 chairs and one tiny little office. We were never in the office together, so it wasn't an issue. But we did have one, we were given access to a terrific secretary. So, I mean, there's so many things. People call my wife Cheryl. People call Keith's wife Terry. They you know, there's so many things that are similar, and sometimes we get mistaken for each other. So.
So what was the craziest case you took care of as an ACS?
Yeah, so the ACS year is the super chief year, the old super chief year, the assistant chief of service. And my craziest case was actually my very first day, which was July the 1st, 1985. And Ken Kern, who was a year ahead of us, left behind. So my first 2 cases were actually repair of eviscerations. dehiscences and eviscerations, little gifts that Ken Kern had left me that sort of needed to be tidied up. One was an esophagectomy and one was a hepatectomy. So we did those in the morning and afternoon, and sure enough, in the evening, admitting many, many different cases, we admitted a fellow named Billy Kane. I'll never forget this case, Billy Kane, and multiple gunshot wounds, and open surgery, repair a hepatic injury, had to do a left nephrectomy, had an aortic injury that we had to repair, and then lo and behold, also had ripped apart the ligament of Treitz. And although we talk about doing Whipples and knowing how to do this stuff, I hadn't really done much in the way of mobilization of the ligament of Treitz, and so we did a duodenectomy, a distal duodenectomy, pancreas sparing duodenectomy, and put them back together. Everything's hand sewn. There's no such thing as damage control. Hadn't been invented yet, essentially. And I was so proud of us that I did it with Dave McFadden, who was chief resident, the senior. We were so proud of ourselves getting this guy through and got him over to the ICU. We left a drain in, and lo and behold, he started bleeding out of his drain. And my big fear was that it was the aorta was bleeding. And lo and behold, he had an accessory left renal artery that we hadn't identified when we did this trauma nephrectomy. So we had to take him back and just put a stitch in the accessory left renal artery. He actually survived and did well, and on discharge he went to the Baltimore City Jail because this was a little bit of a fight between some guys. Some dudes shot him. So that's a pretty dramatic case to have on your first day as a super chief.
We're going to alternate. We can't do all the questions. I'll take the next one.
Yeah, I had one.
My case would have been about Dave McFadden too, but that's all right.
I had a case where we had a 13-year-old girl, and it was a sad story because she was shot by her mother's boyfriend, and she had a temporal brain injury, but she was awake and alert, had a good GCS, and then had a gunshot to her chest, and the bullet was like lodged in her aortopulmonary window, and I was like, great, so I get the 1109, who was Eric Peck at the time, and he comes in, and we take the patient, and we do a median sternotomy, and there's a hole in the pulmonary artery, like right there. And so we're like, okay, and hold it, and we try to put a stitch in it, and it would just bleed, and we couldn't do it. So, and we couldn't put the patient on bypass because of the head injury. So we called the cardiac surgeon, and it was Duke Cameron was on call. And so while we're waiting for him to get there, we could control it with our finger. And I was like, well, let's just try one more time. And then we put the stitch, and it stops bleeding. It stops. Duke Cameron comes in, and we're like, oh, yeah, we fixed it. It's like, no problem. I always think it just wasn't her time. But some crazy stuff. So what was the funniest story from your time at Hopkins, Dr. Lillimo?
So I chose, rather than to say a funny story, I was going to say what really made our time at Hopkins fun was, although we were different, we were tremendous sports fans. And at one time, Charlie still is a very good athlete. We were both very competitive athletes at our various levels, nothing special. But we organized everything, intramural basketball team to play in the Cooley Center. Probably our greatest accomplishment in the highly competitive Cooley Center is we won the basketball championship one year with just a group of surgeons, and we had 6'11" David Efron, and we have a cardiac tech from the research laboratories who played point guard for us. But our match list wasn't about board scores or how many papers they wrote, but whether they had a 3-point shot or could help us in the faculty house staff softball game or the intramural team. In the end, the injuries piled up. Charlie on Thanksgiving Day broke his finger deflecting a pass and had it pinned on Friday morning. And
I remember
the
that.
most dramatic story was we were playing an intramural basketball game, and it was Charlie and I and a bunch of ENT residents and playing against some gawky medical resident. He whacked me right in the face. And I swear I lost a unit of blood. And they took me over to the drenched in blood, laying on this is my blood, not anybody else's. And I'm sitting on the sideline, icing it down. And the ENT residents, after the game was over and we'd beaten the Department of Medicine the ENT guy said, well, what do you want to do? And I said, well, what are my options? They said, well, you can go to the ER. They could take you to the OR and fix it. Number two, you can just ice it and come back and have something done electively. Or, well, we can reduce it right now. And I said, what do you mean? So he basically picked my bid face up, picked it over, slid it back down. You could hear it crunch, crunch, crunch. And I drove home, and I think Charlie got home before I did. And this may be before cell phones, I don't know. But he called Cheryl and said, Keith's not going to look good when he comes back. He's okay. But sports kept us together, kept it very competitive, and we had the best of times. My favorite picture from all of my time at Hopkins is a picture of a couple pictures of Steve, who's a cardiac surgeon at Michigan, Charlie and I on various sports-related things.
Yeah. Dr. Yo, or yeah, I guess you're next. What was your biggest mistake or most memorable mistake?
Yeah, I've made many mistakes, with patients, either in the OR or managing them or even assessing them. So certainly not perfect at all. But the thing that probably got me in some of the worst trouble, so a mistake that leads to consequences, was early on in my AR year, my PGY2 year, where there was a patient who was in the ICU bleeding. And I was asked to go down to the blood bank. And back then, you all remember the blood bank was on Blaylock 6. And there was this little window. And when you went down to pick up blood, you had to have a special little form with you to get the blood. And I had the form, but it wasn't completely filled out correctly. And I handed the form to the person behind the window, who was a blood bank technician. And they made the mistake of showing me the blood, the 4 units of blood, but they said I couldn't have it because the form was incorrectly filled out. And the patient was bleeding, and I'd been instructed to get blood. And the residency is a pyramid, and you have to do what you're told. So I tried to get around. There was a little door you could go into. It was locked, so I actually jumped over jumped through the window and got the blood and brought it back up to the ICU. I don't recommend doing that now because, boy, did I get into trouble.
Even then, right?
And I had to sit down with George Zeitema, and anytime George spoke to you and was mad at you, he would take his glasses and he would put his glasses on the tip of his nose and look at you. And as soon as he reached up for his glasses, you knew you were in big trouble. And we had a little discussion about, the do's and don'ts. And from then on, I always made sure that I had the correct form when I went down to the blood bank. So, but that was clearly a mistake. Clearly a mistake.
When I was a resident, I said this in my talk, I always thought I would never be that attending who lamented for the past and sort of talked about it, but now I'm definitely that attending. I think my generation is probably the most frustrated generation. I say that I've been on the wrong side of the 80-hour work week the whole time. So when I was an intern, I was the first person in the room. I put in the Foley, I wrote the orders, I transported the patients. Then the 80-hour work week came in when I was a chief, so I was the first person in the room, and I put in the Foley, and I wrote the orders, and I transported the patients. Now, I'm the first person in the room, I put in the Foley, I write the orders, I'm like, hey, let the resident know I'm ready to start, So it's just been an interesting transition. We have your generation's work ethic, but I think we really want what the younger generation has advocated for, better ways to integrate our life and stay sane, especially as medicine has evolved. What are the biggest challenges you faced as a resident, and what do you think are the challenges that residents face now?
When you were giving your talk yesterday, you sort of talked about the every other night call and all that stuff, but truthfully, life was much simpler then. It wasn't that we didn't have a life. I had 3 kids through my residency. We had 3 kids through our residency. But the bottom line, you just didn't seem stressed. And I think the biggest difference between residency then is and now is, I think residents are far more stressed than we were. And you didn't have to worry about when you're on call because it was safe to say you were on call most of the time. You didn't worry about doctor's appointments. I told this story to Charlie when we were talking about this. I said, I was flying back from England and I had soft contacts and I wore them far too long and I got a corneal abrasion. So I saw an ophthalmologist and she asked me, well, when's the last time you changed those contacts? And I said, I haven't changed them for 6 years because I hadn't, same pair of soft contacts. I said I disinfect them in a little thing every night, but I hadn't changed them. So I got a pretty stern lecture from that ophthalmologist. And, we didn't, again, I don't want to get into paternity leave, but you can count on your fingers the number of hours I had off on most of the kids' time. But the residents now are far more stressed. They have night call, they have covering for each other with the interviews of fellowship. It is a lot tougher because of the complexity of the patients. And again, I'm just not sure it's as much fun as it was then. And I think it's always been my goal to, make the training as pleasant as it can possibly be and to try to do everything we can to minimize those stresses. Work-life balance didn't exist when we trained because there was no balance. You just worked. And Charlie said, at least for our era, it was the pyramid hanging over you. And we had 12, I think, competing for 4 or 5 slots, and you were scouting out who the competition was, and you didn't want to do anything wrong. But so that was probably the only stress we really had. But otherwise, you just learned a lot, enjoyed what you did, and life was simple. It was tough, but I really feel that for residents now, they have it a lot tougher than we do. And I think it's our job as leaders to do whatever we can to decrease that stress. We're unionizing both of our organizations now. We have not yet signed our contract after 2 years of negotiation. I hear it's, quote, close. But on the other hand, I don't know how that will change things. So it's going to be interesting.
I agree with everything Keith said, but as I was thinking about your question, I thought it was a great question. I think back in our day, we were like Swiss Army knives. If something needed to be done, you got it done. If you needed to draw blood, if you needed to put in a central line, if you needed to put in a Foley, if you needed blood at the VA hospital, if you needed TPN, you mixed it yourself under the hood. If you needed blood at night, you cross-matched the blood. If you needed a blood gas, you ran it yourself. So, it's so different now with all the ancillary services which add different layers. But we really didn't have time to think about work-life balance.
Yeah, in some ways it was just nice. Like you knew your patients, like you only covered your service.
There was no sign out.
Right. Like there was no sign out. You just knew.
But the patients were also not nearly as sick. Obviously,
Right.
the acuity
is so much different.
Hernias were staying in the hospital overnight. Gallbladders were in for 3 or 4 days.
The VA, they stay for a week for a hernia.
Pre-op.
Yeah.
The VA clinic, anybody you saw, you admitted, and you had no idea when you were going to get them on the OR schedule. You didn't care. But yet, at least you had them. They were there.
Right. You had to capture them.
You had to do your sigmoidoscopy before you did your hernia repair.
When I was at Hopkins, you had rolled out your critical pathways, now known as enhanced recovery pathways. I laughed the other day because I asked for a T-tube in the OR, and everybody kind of looked at me with a blank stare. Took some time to find them, but I was telling our residents about the initial Whipple pathway, and every patient had a T-tube. They all had an NG tube for a few days, and then they had a Whipple study. They would get an upper GI and a T-tube cholangiogram, before advancing their diet. How do you think enhanced recovery pathways have changed acuity, and how soon after pancreatectomy are you discharging patients now?
So I think what you just brought up is a really interesting bit of historical importance because, the Whipple back then had a 14-day length of stay. And you're right, everybody had an NG tube for 5 days. Everybody went down to the GI suite for a Whipple study, which usually involved putting gastrografin down the NG tube and injecting contrast in the T tube.
which is never what leaks.
It wouldn't show a leak until you pulled the freaking T-tube out, and then it would leak and they would get sick. And we would have these meetings called M&M, many of them, and we would discuss, well, do you think it would be okay if we stopped putting in T-tubes? Dr. Cameron, do you think it would be okay if we stopped doing the Whipple study? Dr. Cameron, do you think it would be okay if we made a bold move and took the NG tube out on day 3? You know, nowadays things have entirely changed, obviously, and we used to put ring catheters, PTBD catheters in people pre-op to decompress the biliary tree and then do the anastomosis over that, and you know.
For a period, we put them in everybody.
When
I trained, everybody had a PTC.
Even if they had a non-dilated duct, which was crazy. So we've made incredible progress, obviously, but I mean, it was incremental. It was incremental, and all these things were negotiated. There was a negotiation involved.
But, you know, the transition from the mortality of 25% to a Whipple to 2% with a Whipple really started with a handful of great surgeons: John Cameron, Andy Warshaw, Howard Reber, Murray Brennan. I'm sure I'm missing some people. And we were like the second generation, and to see this transition has been great. And it's fun still to kind of teach people a little bit about how we used to do it, but we still have the same complications of DGE and pancreatic leaks. But it's really been a pleasure to see how an operation like Whipple has changed. We've still got a lot of progress to make on survival and cure and the like, but the technical aspects and to see what Herb has done, and I know Jin's done it at Hopkins and many other people have done it, the transition to something being done robotically, when we would be sweating with Dr. Cameron for 5 or 6 hours saying, God damn it, Keith. You know, but it was quite an experience.
Yeah, it's interesting. Like even now, it evolves slowly. Like like now half the time we don't even leave an NG tube, and you know we didn't use pancreatic duct stents when I trained, and now we do everything. Dr. Miko, like I do it kind of totally different than how I learned, and then I just stopped. Like 2 years ago, I just stopped putting in pancreatic duct stents, and nothing happened. So it just continually evolves, and it's nice to see that. We're sending some patients home pretty early now. When we trained, there was little to no formal didactics. We learned because we were on call all the time. You just miss half the good cases. And I would remember we would have GI conference every week. What I really remember the most was running around getting hard copy X-rays for the GI conference, because if you came to the GI conference and you didn't have the X-rays, it wasn't good. M&M didn't actually start till late in my residency, but we didn't have 4 or 5 hours of dedicated OR time, and I don't really recall studying for the ABSITE. We just kind of took it when it came. So how do we best train the surgeon of the future?
So, I mean, training is going to change. We've already seen it happen in cardiac with I6. It's changed in vascular plastics. And I think it's going to continue to evolve. And those of you who are familiar with, many of you were on the committee, the Blue Ribbon panel for the American College of Surgeons that was presented at last year's ASA meeting and published in various stages in annals over the last 6 months, defines a lot of the various thought processes about that. And I do think early specialization is going to happen, and perhaps it will happen in that acute care surgery will become the true general surgery, and everybody else will be a specialist. I think that's evolving that way. I think the keys, though, no matter how surgery evolves, is you have to have dedicated faculty. And if your faculty aren't dedicated to teaching the next generation, then it doesn't matter what kind of program you put together and what kind of didactics or what kind of simulation. You have to have dedicated faculty who are willing to take the time at the threat of decreasing their RVUs or adding length of time so they can't do 3 or 4 sleeve gastrectomies because they help the fellow do it, so they can only do 3. Those are the things that you just have to fight through and set a priority that makes sure you train residents. So I think it's going to be the same. as it's been with respect to dedicated and the principles of surgery, the principles of patient care, the principles of surgical techniques. It's kind of embarrassing now. PGY 4 will come into my, or 5 will come onto my service, and I can tell they haven't sewn an anastomosis for 3 years because everything is stapled. And they do Whipple with me in the first week of July, and they sewed the GI tract for the first time because I hand sew my duodenal jejunostomies. And I used to let the interns do that, but now I kind of have to let the chiefs do it because they haven't stapled everything. So there's still some principles that I think are important.
Yeah, I think this isn't a question on the list, so I apologize, but I think about what I do every day, and there's so many things like in my day-to-day life that are not compensated, right? Like we do them because it's the right thing. Like we do them to train residents and different things. You know, with the junior faculty and the way that compensation models work, everything's become so transactional. You know, like I feel like if we, for example, if we don't incentivize doing the resident interviews, then people won't do it. You know what I mean? They're like, well, okay, if I don't have to do it, then I don't do that. And part of it's like the way the comp models work. You know, how do you sort of create a department where like the faculty are engaged and they're sort of willing to kind of go that extra mile, because we don't get compensated for that. Like we do it because it's the right thing to do.
So it's culture. I mean, it's recruiting the right people. It's understanding that we're obligated to train the next generation. And you know, adding to what Keith said, I remember 30 years ago hearing a talk at an academic surgical meeting about changing the structure of training to 2 or 3 years of core training and then going off to specialty training. And I think now more than ever, that is so on target, you know, to train somebody in GI surgery and not have them be competent in open, robotic, laparoscopic, and endotherapy. You're doing a disservice to the training model. In the same way for the heart surgeons, you know, they're not just doing cabbages anymore. They're doing cabbages and valves and complex cardiac surgery, but they need to be endovascular. They need to put wires in and TAVRs, and also that whole model needs to be. It's going to take some time. It's going to take some iterations, but that's where we need to be.
Yeah. So just switching directions a little bit, but what made you get involved in the SSAT? You know, what SSAT opportunities did you take advantage of, and why do you encourage your faculty to join the SSAT in 2025?
I think your presidential address was just fabulous. I've said that a couple of times, but that slide you had up with all the various societies around it, when we finished, we were general surgeons. We weren't surgical oncologists, we weren't pancreatic surgeons, we weren't HPB surgeons, we were general surgeons, and we tended to operate on the pancreas. And so there was one organization that was perfect for us, and it was the SSAT. I'm sure the SSO might have existed, the colorectal surgery group probably existed, AHPBA did not exist, SAGES did not exist. And so this was the organization to be part of. And of course, John Cameron had been the president, and you know, he opened the door for us in so many different ways, and so it just was a natural. And you know, I think I was on a program committee or this or that, and ultimately became secretary and moved up. And you know, Charlie served the organization more than anybody as running the journal for 8-10 years. I mean, to talk about service to an organization, that was tremendous. So it was the organization to be part of, and I think it's really great that we persist, but we do have to fight the headwinds as people get their travel budgets decreased or they can't be away. You know, American Surgical here 1 week, SSO and the AHPBA are back-to-back weeks in Florida. I mean, the craziness of travel.
ASCRS is here next
people are going to have to make some tough decisions. And for my money, SSAT is a great organization, and we need to support it.
Yeah. Dr. Yo, you became the chair at Jefferson and since 2005. And Dr. Lilimo, you were chair at Indiana from 2003, and then Mass General for the past 14 years. You know, the duration of chairs these days is not as long, you know, so that is really an accomplishment to have weathered that storm. What made you want to be a chair?
Yeah, I mean, I think I was told I was going to be a chair whenever I was recruited to Johns Hopkins, that the role was to be an excellent surgeon and also to take on a leadership role. It was sort of expected. And I think that's a message that we try to pass along to our outstanding graduates. I mean, obviously, there's the ability to set a vision for a department, the ability to do strategic planning, the ability to recruit talented people, and also the ability to interact with the folks in the C-suite. And after listening, and I always joke, when you go to a meeting, whether it's on Zoom or in person, just look around at the people in the meeting and see who brings revenue to the organization and see who drains revenue to the organization. And if the people that drain revenue are greater than 75% of the people at the meeting, then you're in some trouble. You're in some trouble because you're having trouble trying to, you have to convince them of the value of the clinicians that really bring revenue. You know, it's so important that we have a seat at the table when you're talking about academic, educational, research, but even strategy and vision and growth and how to do that in a rational way. It's a great job. The job has changed a lot for me personally. I was recruited to run one hospital, essentially, surgery in one hospital, and now we have 32 hospitals in the system. It's a huge change. So delegation and all. But net, I think it's so satisfying. But there are headwinds. There clearly are headwinds, and the headwinds that are particularly coming are the headwinds of service lines and institutes with individual P&Ls and you know, balance sheets that are different than departmental balance sheets, and so that has become very challenging.
Yeah, what bucket is it in?
Right.
You know,
So, as Charlie said, it really was an expectation. And when we did the FESTRA for John a few years ago, I tallied it up, and the number continues to grow. I think there's 45, 48 chairs that he trained. And you know, I'm proud I've got like 3 now that I can claim, but I really just learned to love working with people as a program director. And it was a golden era. I mean, I just don't want to start naming names, but just a great group of people that are leaders of American surgery just about everywhere. And as the associate program director back then, being a program director was, as you said, it was just looking after the residents. There was no work hours. There was no EPAs. It was just give them a schedule, make sure they got their vacation when they wanted, and deal with their crisis. And every now and then having to sit somebody down and say, you know, you shouldn't have done that to that poor medical resident, even if they had done this. You know, you had to do a little of that. But I think the most important skill set is managing people, because you don't need a MBA to manage a spreadsheet if you got people who prepare them and help you go through them. And what you need to do is manage people and make decisions that benefit people. And I think, to me, that's why I wanted to do it, because having been the program director, I thought how great it would be to expand my ability to help people the level beyond residents. It's far more complex. Residents are easy to manage compared to faculty, but still, it gave me the desire to you know, to help people at different levels.
when I think back to the times of Zydeman and Cameron, maybe because I didn't live it, you know, it seemed like the role of chair was just like this great job, and it didn't really evolve that much. But over the time period that you have been chairs, like, it has evolved significantly. You talked about the expectation. It's like, yeah, like, I don't know, that is the definition of success. Like, you need to do this, and then you need to go and become a chair. But, you know, it seems like in modern medicine, there are a lot more paths to success. You know, Dr. Townsend always says to me, he's like, you know, you need to be in the hospital leadership. He's like, that's where the money is, you know. It's like, and so how do you see, like, different paths to success in academic surgery now? Is it being a chair? Like, is that the definition? Dr. Cameron always thinks so, because he certainly told me that yesterday, but yeah.
Well, Keith just said, I would, in a nutshell, I'd say a lot of it's emotional intelligence in the ability to deal with people. But yeah, there are many different paths to success. There's a couple caveats, though, and I've seen some very talented faculty who have gone into the C-suite and who have decremented their clinical work, and then there's been a new administration come in, or the health system turns over, and they become redundant. and they've sort of, they're in some trouble career-wise. But certainly, institute leaders, service line leadership, two other roles that people can have that can be a lot of fun, as long as you have the right resources, and as long as there's a understanding of what the role of the chair is versus the role of the institute leader, and that's evolving.
I think it's really hard. Like when I think of how medicine has evolved, historically we were surgeons. We wanted to be in the operating room. We didn't want to be in the C-suite. And then I think, you wake up 20 years later and you're like, well, how did it evolve this way? And it's because we didn't have a seat at the table. But I think it's hard to get surgeons even now to want to have a seat at the table for all the reasons you say. Our administration at Banner changes every 3 years. It's like, they new people and they're out and they're in, and so how do we get a voice, sort of at that level, or how do you get people interested and want to do that when, 3 years from now they'll say, oh no, now we're restructuring and changing all our medical directors, and the way this is going to be.
Dr. Blaylock said in one of his speeches that the surgeon should be in the OR often and every day. That's very hard to do within a leadership position, but in my mind, you need to be in the OR 2 or 3 times a week. And you also have to control your schedule so that when they tell you they're going to have a meeting at noon on a Wednesday, you say, well, I'm available, but I'm available at 6 a.m., 7 a.m., or 5 p.m., or 6 p.m.
Yeah,
but not at
10 o'clock.
noon because I'm going to be in the OR and I'm not scrubbing out to be at a meeting. I think you have to have a little seniority in the organization, and the organization needs to value your input. I'd be curious how you handled all that.
I only operate 1 day a week. I've done that all 14 years. I have Friday. It means I always have a post-op Whipple on Saturday, so I don't get a lot of weekends without having to go in to see my patients. But I think you have to adapt. I mean, when you're told that Wednesday is administration day, you got to make sure Wednesday is your administration day, and Thursday is our education day, and so you have to work around that because, again, if you're not at the table, the decisions will be made without you. And I think that I guess your question is, how do we want to motivate, the next generation to do that? And I think it's by showing success stories. Peter Pisters, Selwyn Vickers. I mean, the 2 leading cancer centers in the world are run by surgeons. And that's because they have the skill set and the ability to multitask and make decisions and be fair and transparent. And you hold up Peter and Selwyn as great examples of success stories. It makes you confident that surgeons can and should do this. There'll be examples that people don't do so well, and I think that's the biggest risk, is you get kind of caught in the intermediate stage, and all of a sudden you've got a board that changes or something along those lines, and then your career is sort of over. I mean, if you've gone that direction, you've lost your practice, you've lost your academic connections, it's hard to go back and be a surgeon again. So I think there is a little risk in taking that, but I think the more examples as we set, the people who have been extraordinarily successful, and I can, Henry Ford, there's so many people that fall into that category who have been successful, but there's been a few failures along the line too.
You both have sort of alluded to emotional intelligence, and I think about like the complex matrix systems that we work in. Our traditional model, that academic triple threat, like not every surgeon in my department is going to be the academic triple threat, right? So I have to make my whole division or my whole department that, but it just becomes just really challenging to like get people to see like the value of their unique contribution to sort of that bigger picture. I also think as the role of chair evolves, people are not chairs for as long as you were chairs. Do you think chairs should have term limits? In my 20th year going, I would say yes, because it's very easy to say it in retrospect. But I do think there's an advantage. I just did my 3rd 6-year self-study review. I think there's an advantage to that, whether it's every 5, 6, 7 years, and have your department reviewed externally and have smart people come in and make some suggestions.
We've all done that sort of stuff, being external reviewers, and you want to try to help the department get better. You're not there to be punitive, you're there to help the department get better. I do think, particularly nowadays, resources are harder and harder to obtain. The old chair recruitment packages that used to be very common, you'd write a vision statement, you'd show the strategy, you'd say, here's what I need. At least in my organization, $15 billion organization, those packages aren't as heavy as they used to be. And so you have to rely on philanthropy, you have to rely on external funding, which can be harder and harder to get with what's going on in DC now. So clearly there's changes, but I do think there's an advantage to turning things over. But there's a risk there too. There's clearly a risk there.
With not everybody being the traditional academic triple threat, the criteria we use to recruit chairs is still that traditional thing, but I'm not sure that those are the skills that people need to succeed in the complex matrix environments that we work in. Like, do you think the criteria for how we choose chairs need to change?
It probably hasn't as much as it should, because the searches are tended to be run by academic search committees, and they look at publications, they look at research. They probably don't pay too much attention to how big your clinical volume is, and they look at the national profile of people. But I really do think the important qualities that search committees need to look for are people who are willing to set aside their own priorities for the growth of the institution, to be a team member, whether it be informing an institute, informing a cancer center, in building a transplant program, because they're all multidisciplinary. And if you can't come in and say, I'm going to be the most powerful person at this hospital,
you're middle management.
It is middle management. So you've got to look for qualities of collaboration, cooperation, and people are really dedicated to the missions, and all the missions. And you're not going to get a chair these days who can build your research programs, build your clinical programs, improve your residency. People don't have all those skill sets, but they've also got to be able to recruit the right people who have the right vision. And I think that's very important, is how you, when you become a chair, is set the vision of your organization by the people you empower into the various positions. So.
What are the experiences that have really, life experiences, chair experiences, that have changed or shaped your perspective as your careers have developed?
Well, I mean, that's an all-encompassing question, right? I mean, I think we all hope to grow and grow wiser as we age, to make proper decisions, to value family and friends. That was something that was hard to do during residency, but much easier to do as you get a bit older. And overall, it's such a joy, I think, being having the responsibility to push people up, to use Keith's word, empower people, to elevate them, to see them grow, whether it's the residents, the fellows, or the medical students. I think that's where you get most of your satisfaction. In addition to what you alluded to yesterday, just taking care of patients. It's what an honor it is to take care of patients and to see them thrive. Not that we're 100% successful. So it's a combination of things, I think.
You were very gracious in your introduction, and people would say, wow, these guys have had just this great career. But we all know we've had bumps in the roads and disappointments and things like that. And I think, the number one thing is that you never keep trying to get yourself better. You never stop trying to do the right thing. You pick up my move to Indiana, in hindsight, was the best thing that ever happened to me, because I was able to kind of, as you say, build something myself with, again, bringing in the right people and changing an institution that has, I think, really come a long ways in the 20 years since I went there. So I've very much enjoyed that, and I think my time at the MGH too has been a transition time, and so again, every time you hear of a success story, there's some backstories that aren't always as much fun of our lives too.
Yeah, I think we all hear, like I said, the Facebook version of everybody's lives, but in reality, it's never this linear upward trajectory. There's a lot of bumps in the road for sure. With the increasing corporatization of healthcare and compensation models, and in Boston's like the Game of Thrones right now. But how have you been able to preserve the academic mission?
Money is what drives the academic mission. Supporting research, particularly if indirects get cut, being able to provide startup packages to get new people going in their careers, be able to recruit people to build programs, and on the other hand, you can't let everybody think that money is the only thing that drives success. So I think the most important thing is to have a well-functioning clinical department that is productive, that adds to the hospital margin and adds to your own department's margin, no matter how that's calculated, and show the success and have the rewards that you can then say, but now I need to invest in having my residents take 2 years off for research when there's nobody to pay for them. There's no philanthropy. There's not enough training grants to go around, et cetera. So I do think that there is a balance, and I think most people accept that, and the problem is it's just getting tougher and tougher.
Our departments probably couldn't be, we've talked about this, but it couldn't be more different because the MGH is a powerhouse in research, huge endowment. Philadelphia is just as competitive as Boston, so there's some similarities there, but the department I came to, storied history, now 201 years old, but not a large endowment, very little in the way of research. And it's been fun to grow that from a faculty of 20 to almost 100. It's taken 20 years. But I mean, the key elements are the people, that they're clinically very talented, and that we can show on the hospital side that there's a contribution margin that they're proud of and that they want to continue to keep investing in. And then adding into that really eleemosynary activities, philanthropy, trying to leverage the value of people who are grateful, whether it's people or industries who are grateful and who are willing to support small projects that can be pilot grant projects to launch into larger grants. So I mean, I think that's the way I've had to approach it, because I didn't come in with, we're 65 in the Blue Ridge, right? Jefferson's 65 in the Blue Ridge. So we're not talking about multi-million-dollar research funds.
Yeah, I asked you about philanthropy just for that. My department doesn't not have like a lot of endowed chairs or a lot of philanthropy, and when we deal with our like development officers and stuff, they're looking for people who want to leave like $10 million. But I think about running a marathon or raising money for the diaper bank, and I can ask people and they raise like $26,000. I'm like, well, what if all those patients, like you just said, they can give you $10 or $100 or $1,000, like that would add up. But I don't know how to ask that without it feeling like hey, we just did your operation, now you want to give us money. Like, how do we? But we're going to have to think of different models, like to support what we want to do, especially in places that are not as funded as Michigan or the MGH or Hopkins.
Well, what we've had to do, one of our, we all have checklists. We all have things that require our faculty to do. And one of the things on our checklist is every patient you operate on, we ask you to submit the name to development. Not to reach out to the patient themselves, but to submit the name to development so that they can do a little background check. And then, send them a thank you note. Thank you for coming to Jefferson for your care. And you're right. I mean, I'd rather have $10 million gifts, but, do the math. I'll take $10,000 gifts, and so.
If I had $100,000 gifts, I could support 2 research people
absolutely.
and residents, and right.
So I think you have to really, if you're not a wealthy department, you have to look for alternative ways.
Yeah. So I think we have a few more minutes, and I was just going to end with a quick, this or that. So we play this at the hockey game all the time. So this or that, Whipple or Distal?
For me, the Whipple is the most fun thing you can do with your clothes on. So.
It's a very satisfying, technically challenging case. There are times in the case they're very tough, and there's times in the post-operative period they're very tough, and sometimes the outcomes are not long-term as good as you'd like, but there is a lot of satisfaction to particularly helping a chief resident do their first Whipple. I did first Whipples with a lot of people myself during the years, and I think
First time, every time.
that's very important. So there's not just a technical satisfaction, but the feeling of having a good day with a good resident, and I think that's more satisfying. And so I guess I'd say the Whipple side of it. You get to sew again, as opposed to just firing a stapler and being done.
Okay, Dr. Yo, New Jersey, Baltimore, or Philly?
Oh, gosh. I'd say probably Philly because there's Eagles, who won a little football game a few months ago. But we love Baltimore. Terry and I love, 30 years in Baltimore, wonderful. We loved Hopkins. We loved the Inner Harbor. And, like you, I grew up in Jersey, but when we were moving to Philadelphia, and we were with the real estate agent, they said, well, you can live in Delaware, because at Jefferson you can live in Delaware, New Jersey, or Pennsylvania. And Terry chimed in, she said, I'm not living in New Jersey. I'll never forget that.
But you don't have to pump your own gas, which is really nice, yeah. Dr. Lemma, South Dakota, Baltimore, or Boston?
Or you could put Indy in there as well.
Yeah, Indiana, true.
Yeah. I'll go with Baltimore. Because 29 years.
I know Cheryl's answer.
Yeah, Cheryl's answer. Cheryl's in Baltimore right now.
Right.
We've got a home in Baltimore. We're going to retire in Baltimore, and we've had a great run in Boston and great friends, but we've never had kids in Boston. And if you build your friendships around your kids at soccer games or swim meets or school programs and stuff like that. And so we've probably have more friends in Baltimore or related to Baltimore through all the alums and things like that. So I'll say Baltimore probably.
All right, this one's easy for you. Steak or sushi?
Steak.
I like sushi. I like steak too, though. So.
Okay, Coke or Pepsi?
Without a doubt, Coke.
Coke Zero.
Yeah, Coke Zero, yeah.
I'm a traditionalist.
Yeah.
Well, I want to thank you both for coming and participating in this session. It's been really fun, and really, you are both legends to me, and I thank you for everything you've done. Thank you for being here.
Thanks, guys.